Thank you very much. I will ask to all the speakers to sit here in the front. If you have any question, feel free to ask. We'll start with the talk on anatomy made by Pau Golano. Any question, Pau? Yes, we have one there from the speaker.
Again, I'd like to thank Pau for his beautiful anatomy and the blending of art and science, which just always blows me away. The question I have is the anatomy that you describe, and you touched on it very briefly, is almost invariably of aged specimens. And we know elsewhere that the anatomy varies with age, and just about everybody we see in a sporting context, definitely below 40, typically below 30, there's a gap there for us to be able to describe the anatomy of the young, healthy person with pathology versus the 70, 80, 90-year-old with degenerate pathology.
Yeah, of course, I agree with this. It's one of the problems to work in cadavers with all specimens. I'm sure there's many changes in the joint. It's not only in the shoulder, in all the joints we have this problem. Maybe if we have the possibility to dissect the young people, we can see better the ligaments. Maybe we see better other things.
I have a question for Pau. Probably you saw all these things in the newspapers saying that we have found a new ligament in the knee.
Yeah.
So is there any new ligament in the shoulder? Why is there no ligament between the posterior band of the IGHL and the superior part of the shoulder? There's no ligament in this posterior capsule. We have 3 in the front, 1 in the inferiorly, and no ligament in the posterior part.
Yeah. Why not? Yeah. Maybe we can describe.
Okay. Because when Ben is describing this contracture of the posterior capsule, it is the whole capsule is contracted, or is there any ligaments over there? Ben, do you think? What do you think?
I have not described that posterior capsular contracture. That was done by other people, and if you look at that, it's always from that lower level down from the posterior band down around that 7 or 8 o'clock. If the contracture is there, I think it's a thickening of the other structures that are already there. My own opinion on why you have that is there's a lot of muscular component as well as capsular component. But that area of thickening that you can either see on MRI or look clinically, it's down around that 8 o'clock to 6 o'clock position. So it's probably more thickening of that normal thickening band there.
Thank you. And there's some controversies about the IGHL, inferior glenohumeral ligament. It was described with an anterior band, a posterior band. And there's some anatomists who say there's no anterior band and no posterior band. It's just one ligament. How often do you see the band?
I see never.
Never?
Never.
Okay, so there's no anterior band and posterior band.
No, but finally, the moment if you arrive in the capsule joint, you have a scapula, humor. It's very difficult to exactly define what is the limits of the structure. This is my opinion. Maybe I don't have this ability to see these structures. But I see the works of Nicole Pouliat. It's a very nice work, but for me it's impossible to understand the message of these works, but it's very difficult.
Okay, thank you. Any question? So we can move to the next talk on the made by Ronnie Whiteley on the biomechanics. Is there any question on biomechanics? Yes, there's a question there.
Joint. And my question is, I had trouble to explain it to myself biomechanically, so I was thinking, do you have any ideas on that? Does it have to do with the dysfunction of the shoulder, and how does it work?
Sure. So perhaps to paraphrase the question, a clinical case series showing subluxation of the SC joint in a series of swimmers, and can biomechanics shed any light on that? Tragically, in short, no. But the biomechanics of swimmers hasn't been terribly well described because largely the technical difficulties of getting 3D analysis of people under the water. There are some things that might point us in the right direction. There's some work being done which is looking at variations in strength and in particular in cuff strength, and there's significantly a subset of swimmers who display atypical changes in cuff strength. Typically we'll see posterior-superior cuff failure, and while that's common in swimmers, present with an abnormally high number of internal rotation strength deficits. Clinically, you'd see the postural alterations associated with swimmers, particularly of protraction and forward positioning. And my suspicion with being the only spot where the shoulder's tied onto the axial skeleton here, that's going to place relatively large loads through the sternoclavicular joint. And no doubt your experience would be similar, that these are really difficult to manage conservatively, surgically, any other way. So it's a problem that we don't really know how to avoid, and we certainly don't have a good handle on treating, tragically.
Without seeming to say everything wrong with the shoulder is due to scapular problems, when we don't understand, but that's exactly right. Remember, this is a compression and an anterior shear injury, and the reason for that is swimmers do not use the ground; they have their hips as the ground, and so if you look at those swimmers, they will have weak hips as well. And what they're doing is they're protracting this way, and so they get this horizontal adduction, but then as they come forward, actually there is a anterior instability right here. I have tried everything in terms of getting these better, and there's a certain point beyond which you can't, but if you obviously want to do all the dry land exercises, all the core stability, scapular retraction, all that stuff, if you do have to do surgery, there's a little disc in there that gets injured, but mainly what you find is those anterior inferior ligament fibers running between the sternum and the clavicle and also the first rib are stretched. And I've actually gone in there and done a instability repair on those, and that will stabilize along with everything else. But it's a very difficult. But it's because of this and this right here, and they've got their technique is they're out here too far. Their lat and their pectoralis are pulling everything forward. And the lat, especially in the pec, they will tend to, through their influence on the arm, pull the whole shoulder complex forward. And so they're way out here reaching, and they just do this and just beat this up pretty bad in some people.
Thank you. No more question. Rod, what is the role of the biceps? Long head of the biceps. What is the role?
In normal anatomy, in pathology, or keeping surgeons in business?
I must say in the pathomechanics and in the physiology and the mechanics of the shoulder. What is the role of the long head of biceps?
Yeah, certainly a very controversial area, and probably. Okay, so I think what you're getting around is the tenodesis or not for these guys, and there's some sectioning studies and some biomechanical modelling studies would say that 1/5 of your restraint towards anterior instability is provided by the long head of the biceps with your arm in that abducted, externally rotated position. So you lose that guy, you've effectively lost one guy on your basketball team of 5. Doesn't mean you still can't play. You've still got 4 other guys who can maintain anterior stability, but it makes it a whole bunch harder for those other guys. So once it becomes pathologically irretrievable, then I would suspect it's time to do something significant about it. But whilst ever you can save it, it's going to make life easier for all of the other structures, and I'd suggest it very rarely exists in isolation of other pathologies.
I think you have to look at what population you're dealing with. There's several interesting studies. Greg Bain, I think y'all remember Greg, he did a anatomy study that just came out in Clinical Anatomy this past year, and he looked at the difference between the inferior labrum and superior labrum, and he showed that it appears that the biceps labrum complex works more like a tension band in stability. I mean, so that what's the tension band do? Under tension, it develops compression, whether it's in abduction rotation or in forward flexion. So there is a role. And there's a very good study out of AJSM 2006, looked at the fibers. They run from the biceps 95% of them run into the posterior labrum, and then they come down the backside of the labrum. They actually are about 8 o'clock. A large proportion will go into this posterior band or where it is back there. And Guillermo and I have seen this several times where you take that I think it's type 7 labral tear, and you'll see a split that runs right into the substance of the fibers and then down the posterior band. So very definitely, this whole idea of this posterior cuff to restrain the ball in the socket, I think really does exist, and the labrum and the biceps and this band play all roles. Now, what if you take out the biceps? What do you have to replace it? You have the co-contraction, compression of the rotator cuff. So in low load motions that are in through here, not extremes of motion, not high lows, not repetitive, the muscles can approximate this very well. It's only who needs a biceps at the shoulder? It's the guys who do this. That's the only guys who really need a biceps for maximal glenohumeral kinematics. And so for that reason, you can treat it rather roughly in a lot of patients. And obviously there's time when you need to fix it, but you do remove the tension band and you remove a little bit of that protection against instability that is usually made up by positioning the scapula and glenoid and also the rotator cuff.
Could I just add to that? One of the things I had to leave out was, I think, the landmark paper on the anatomy of the labrum published in Arthroscopy, I think in 2003 by Huber and Putz. They described it as the periarticular fibre system, and I think elegantly they started off at macroscopic dissection, went all the way down to electron microscopy of this periarticular fibre system, or what we'd call the glenoid labrum. And they showed that in essence the glenoid labrum is the fibrocartilaginous extension, or the enthesis, of the long head of the biceps tendon superiorly and the long head of the triceps tendon inferiorly, such that these become a circumferential attachment of these tendons all the way around. The only other thing I'd add to what Ben has said is I too had thought forever that, well, it's the cuff is going to co-contract and hold it in place, but more recent, and there's been some technical difficulties which have masked this, but more recent EMG analysis show that the cuff doesn't co-contract. The cuff has an on-off task-specific, movement-specific activation pattern. So our old thought of it, well, everything turns on and pulls it in. When you're doing rotation, it doesn't make a lot of sense if I'm doing resisted internal rotation to turn my external rotators on, and in fact that's what the EMG stuff shows us.
Thank you. If there's no other question, we can move to the next talk made by Ben Kibler on the physical examination. Is there any question? Ben, there's a trend now in let's say in Europe of saying that physicians, clinicians should use ultrasound. Ultrasound is something that will help the clinical exam. Do you use ultrasound? Do you believe in this?
Yes, ultrasound is dynamic, just like the exam can be. It can show you some things, can't show you everything, can't show you all the things about the labrum very well at all, but it certainly can look at all the rotator cuff, it can look at the biceps, it can't look at the inferior, or it can't tell you much about the anterior inferior labrum as well, but for the things that you can see, it's been very, very helpful. And I still use it as a confirmation, because no matter what it shows, even though it is dynamic, it only shows you things that may or may not have anything to do with what the patient is telling you about. But yes, we use ultrasound quite a bit. We're learning. It's what's called operator dependent. I mean, I still can't see everything that other people can see, but I'm getting better at it.
You use it yourself? You have
Yes, yes. So yeah, we have our unit right there, and we'll just take the patient over there and do it right there.
Thank you. No other question? So we can move to the last talk on imaging. Imad, you told us about the injections technique. How often is Philippe and the other physician asking you to make injections of lidocaine under arthrography, just to be sure where the pain is coming from?
It's not specifically asked. I just do it as a routine. It's just the way I've been practicing. So I keep 5 cc's of lidocaine in there.
Because when we see this what we call the mysterious shoulder,
yeah.
We don't know, then we need you. So how often do you use bone scan? How often do you use injections of lidocaine in the joint? because we don't know if it's intra-articular or extra-articular, where is the pain coming from.
Right. Well, bone scan very infrequently. We don't really do the nuclear medicine bone scan, but for the arthrogram, also with the hip surgeons we've worked with, also ask us to inject steroid. So they don't rely on what we've said immediately. They'll come back and see the patient later, 2 weeks, and they'll say, did you get better? So before they go for hip arthroscopy, they'll make their decision based on that, not just on the imaging, plus their clinical findings as well.
Philippe, I'd ask you the question then. What information do you get out of these differential, say you put it into the joint? How does that help you? Because what you've done basically is anesthetized maybe all the joint, maybe some of the joint. What does that tell you about the mystery shoulder?
If I often ask for an injection, intra-articular injection of the of lidocaine while they are doing arthro-CT. And if the arthro-CT is normal and the injection is negative, I forget about using my scope. And if the arthro-CT is normal and the injection is positive, I might use my scope. That's how I use it, just to prevent me from putting the scope in the shoulder without anything. And we say in France that if you make a white arthroscopy, it is the beginning of a black series.
Is that after one injection or 2 injections?
Just injection of lidocaine in the joint while you are asking for an arthro-CT. If the patient says for 1 hour it was pain-free, there's something in the joint, you're sure. If the patient says there was no difference, you might doubt that it's coming from the joint. It's coming from the muscles, coming from the scapulothoracic joint, whatever, but not the glenohumeral joint.
I could speak also from experience. When I had my arthrogram, there was a constant aching pain. As soon as I got up off the table, it was complete relief. And right then I said, okay, fine, I'm doing it. Despite what the surgeon told me, he's like, this could lead to arthritis, complications. I didn't want to do it. After the arthrogram, I said, wow, I've been living with this, and then I decided to do the surgery. So,
Just to put a scope into a patient because they got better from injection, you can do that in the knee, and you can get some relief if you're pain in the knee. And there's a lot of studies show that now, if you just kind of clean it out, that doesn't last. So I would like to have a little bit more information about what's going on inside the shoulder before I would feel like there would be a need to put a scope in there. What else? What other information would you use plus in addition to the relief of symptoms? You'd want some kind of physical findings or some kind of history findings.
No, it's mainly for painful shoulder. If there's something on the arthro-CT, then it's done. You've got the diagnosis.
Mm-hmm.
But if you have a almost normal arthro-CT but a positive test with lidocaine, then I might think using my scope to make a diagnostic arthroscopy. But if there's no pain relief and a normal arthro-CT, I try to find something else, neurological, whatever you want, but nothing inside the joint. If I am sure that the injection was made by a radiologist, I don't trust my own injections. Well, thank you very much. It was a nice session. Now we have a pause of 15 minutes.